Hello, everyone. Welcome to the Opioid Learning Institute's third Grand Rounds Case Review session. My name is Caitlin McTernan, and I am an Education and Training Associate at Health HIV. I'm also joined by my colleague, Michelle Rogers, who is the Capacity Building Manager here. And I first want to make all participants aware that if you wish to ask a question of the panel, to please use the Q&A box on the bottom of the screen, and I will moderate your questions to the panel. I'm going to go through the next few slides rather quickly as they pertain mainly to our accreditation process, and this information will be available to all participants after the session. So first and foremost, this activity is intended for doctors, physician assistants, nurse practitioners, registered nurses, pharmacists, psychologists, and social workers engaged in the treatment of opioid use disorder. And some learning objectives of the session are to review the latest research and discuss advances in relation to treating individuals with opioid use disorder, and to also facilitate discussions surrounding difficulties in treating opioid use disorder in relation to some specific patient cases, including barriers to care, treatment plan, and treatment plan challenges. So the next few slides contain some information regarding conflict of interest statements. And you can see on this chart depicts that the disclosures from our panelists and health HIV staff. The PIMS and health HIV managers have nothing to disclose. Here you can see the accreditation statement from PIMS, followed by the types of credit you can obtain for participating in this session today. So you can obtain a physician continuing education, continuing pharmacy education, continuing nursing education, continuing physician assistant education, and continuing social worker education. To obtain your credits at the conclusion of the session, you can visit www.cmuuniversity.com and search the course ID. This will be sent to all participants at the conclusion of this session. And this slide just goes over the type of computer hardware and software needed to participate in this activity. So you'll need a computer with audio and visual capabilities or a phone. And then just to summarize the next two slides, the opinions expressed in this activity do not necessarily represent the views of the planners. So you can refer to official prescribing information for discussion of approved indications, contraindications, and warnings. And then additionally, the information presented in this activity is not meant to serve as a guideline for patient management. And with that, I would like to introduce the Opioid Learning Institute, which is led by Health HIV and funded by DC Health, HIV/AIDS, Hepatitis, STD, and TB Administration. It is a comprehensive educational initiative with a mission to educate prescribers and other healthcare professionals on safe and effective opioid prescribing practices. It is a self-paced, accredited curriculum that covers a range of topics in relation to treating opioid use disorder. For more information, you can visit opioidhealth.org to access the 12 e-learning modules and other opioid-related resources. Today's session is a case-based, free continuing education opportunity that allows providers in Washington, D.C. to review the latest research, respond to case studies, and discuss treatment advances related to treating individuals with opioid use disorder. And just to reiterate, this program is funded by HOSTA. And before we begin our discussion, I would like to introduce you to our panelists. And first, I want to thank all the panelists for taking the time to facilitate our discussion today based on your experience working with clients with opioid use disorder. And we would love to start the conversation with some introduction. So if you would like to give the audience a brief background about your experience with opioid use disorder, that would be great. And if we could start with Catherine, that would be awesome.
Sure. Thanks, Caitlin. I'm khkjhbjkhj. I'm a physician assistant by training. I work at Mary Center. I'm the medical director of the Adams Morgan site here, and I work on the MAT team. I've been a part of the team since about 2017 when I obtained my X waiver. In our program, we see nearly 200 patients for various substance use disorders and treat a variety of patients with buprenorphine.
Great, thank you. And then we can move on to Dr. Rosenblatt.
Hi, good afternoon. I'm Seth Rosenblatt. I am a psychiatrist at Whitman-Walker Health, which is a federally qualified health center in D.C. I provide MAT for a wide array of clients. We have 2 different sites that we provide MAT services at, on 14th Street and then in Southeast at the Max Robinson Center. I've been doing that for about 3 years, and we also have a team of primary care providers as well at our sites that are helping to provide MAT services to clients.
Great, thank you. And then we can move to Dr. Rosenthal.
Hi, I'm Alana Rosenthal. I'm an infectious disease specialist from the University of Maryland. My work is predominantly clinical research looking at the intersection of substance use disorder and infectious diseases. And in that capacity, I do buprenorphine treatment at HIPS, which is a harm reduction organization. We have buprenorphine treatment embedded in their drop-in center. And a lot of our treatment is buprenorphine treatment co-located with infectious disease care.
Great, thank you. And then we can move to Mari.
Hi, my name is Mary Lowe. I'm a family nurse practitioner. I work at Unity Healthcare at Christ House, which is a homeless medical respite in Adams Morgan. I've been prescribing buprenorphine for about 3 years when I got waivered, first at an outpatient federally qualified health center and then now at the inpatient medical respite.
Great. So with that, that's all of our panelists, and we're very excited to have them, especially with the varying experiences we have within the field of opioid use disorder. And with that, we can move on to review our first case, which is submitted by Dr. Elena Rosenthal, and I will now turn it over to her to present this patient's case.
All right, so this is a patient who is a 65-year-old man with unstable housing, opioid use disorder on buprenorphine, and hepatitis C status post-treatment, who was found to have laryngeal cancer. And the problem that I wanted to discuss today is how to do acute pain management in the setting of opioid use disorder and opioid agonist therapy. So this patient initially presented to our clinic with hepatitis C and was engaged in treatment for his hepatitis C and achieved cure. He suffered from comorbid opioid use disorder, and at the time that we met him was injecting heroin 3 times a day. So during the course of his hepatitis C treatment, we were able to get him started on buprenorphine, to which he was fully adherent to appointments and generally abstinent, often having negative urine drug screens, so due to his periods of homelessness, did have some what he called slips. During the course of his treatment, we noticed that he had an increasingly raspy voice, and he was referred to ENT and found to have laryngeal cancer. He underwent emergency surgery, including a laryngectomy for a partially obstructing mass. And while he was inpatient, his buprenorphine was stopped, and he was treated with short-acting opiates. The patient was then discharged a few days later with a prescription for oxycodone, 5 milligrams for 10 pills. And we became aware of it because I received a call from the pharmacy reporting that the patient was attempting to pick up narcotics for which he was banned because he's on buprenorphine. And so the question that I wanted to pose to the group was, what's the best way to address acute pain in a patient like this while continuing to address his opioid use disorder? So a little bit more about the patient in terms of his past drug history. He had used heroin for 30 years and was predominantly injecting heroin. We had started him on buprenorphine and with the result of a significant decrease in his heroin use, but that was being held during his hospitalization. He had some alcohol misuse off and on, but none at the time of this presentation. In terms of his past medical history, He had hepatitis C, which was cured, laryngeal cancer, which was active, and hypertension, which was